All right. Hi, everybody. Welcome to your next to last online lecture for BL 620 Biomedical Microbiology. Today, we're going to talk about protozoan pathogens or protozoan parasites. And when I was looking for some quotes to share with you guys about parasites, the one that continually pops up is this one from The Hot Zone. If you've ever read The Hot Zone, the movie Outbreak is kind of loosely based on The Hot Zone. It says, the Earth is attempting to rid itself of an infection by a human parasite. And I think that's kind of ironic that that's the quote that kept popping up given the current situation that we're in with the zoonotic infection wreaking havoc on the world and on our daily lives. But then the second quote here is about Toxoplasma gondii, which we're going to talk about today. And this one's by Ed Yong from the book I Contain Multitudes. If you're interested in learning more about the microbiome of humans and of other animals and how they develop and what they can do, I really recommend this book. It's really good. So I'll let you read this on its own as it relates to today's lecture. Right? Okay, so our case study for today. We have a 59-year-old North Carolina man who fell ill after visiting Fantasy Lake Water Park in July, and this happened in July of last summer. So this is a true case. The link to the case report is down here on your slides. 5 days later, he began to experience headache, nausea, and vomiting. 2 days later, the man reported to the emergency department with a severe headache and stiff neck, which was initially diagnosed as bacterial meningitis. He was admitted and started on IV antibiotics like you would treat bacterial meningitis. However, within hours of admittance, he began hallucinating and having seizures. By the second day in hospital, he became comatose and expired 2 days later. So what do you think, guys? Pause it. Think about what you remember from learning about like meningococcemia, meningitis caused by that one, either Neisseria meningitidis or Streptococcus pneumoniae, and think, do these fit the symptoms for either of those? And then think about how this man might have contracted this particular disease. And we'll come back to this one like we always do later on during the lecture. Okay, so today's learning outcomes. By the end of this, I want you guys to understand some of the new terminology that's associated with protozoan pathogens or parasites, to identify the diseases caused by these pathogens based on signs and symptoms, describe morphological changes pathogens may undergo as they move into and through the body from the environment. So these will include words like excistation and incystation, words ending in something like zooites, and to list at-risk populations for some of these different diseases. Okay, so parasitology. You guys have all heard this term before. Maybe you've taken a class on parasitology. Side note, my favorite class I took in undergrad was actually parasitology, and I'd love to have the opportunity to teach just a class on parasites one of these days. But anyway, you guys know that a parasitic relationship or parasitism is defined as a relationship in which one organism benefits at the expense of another. Or we often say this as one partner benefits, the other partner is harmed. Okay, so that's a parasitic relationship. And the parasite is the organism that's benefiting. So we use the word parasite pretty broadly in our everyday speech, but when we talk about parasites in medical microbiology, we are talking specifically about an organism or organisms that are physiologically dependent upon their host for survival and belong to the major taxonomic groups of protozoans, platyhelminthes, and nematohelminthes, okay? So we think of things being parasites, like we can think of intracellular parasites like the rickettsias or all viruses, because they have to rely on host things to replicate. But when we use the word parasite in medical microbiology, we are referring specifically to protozoans or to the helminths, either the flatworms or the roundworms, okay? So we give it a more specific meaning in medical microbiology. So why should we care about protozoans? We don't hear about them a lot, right? When you think about infectious diseases, you think more about bacteria and viruses. And in the United States, protozoan parasites and helminthic parasites are not a really huge problem, but there are a number of these diseases that affect people worldwide. So amoebiasis, or diseases caused by amoebas, it's estimated that about 10% of the world's population is affected, and there's anywhere between 40 and 110,000 deaths annually due to amoebic infections of various types. Giardiasis, this is one you've probably heard of, Giardia. It can affect about 200 million people in the world's population, live in areas where we get giardiasis. Malaria, about 500 million people are affected by malaria. It's estimated that 3 billion people are at risk. This annual deaths actually should be decreased. I should have checked this. I looked up this data the other day because I was having a conversation about malaria with my college cell biology professor. And the estimates are still that there are 1 million new cases of malaria each year and about 500,000 deaths due to malaria each year. Leishmaniasis, trypanosomiasis, and there are trypanosomes in the US, causes Chagas disease. And then schistosomiasis, which has a weird life cycle that involves snails and fresh water and getting into people as they're swimming in these areas of water that have these snails. It's very weird. We don't have it here. There's actually a lot of schistosomiasis in Southeast Asia and in Egypt along the Nile River. Okay, so about half the world's population lives in areas where malaria transmission does or could occur. And if you have a goal of working for an organization like Doctors Without Borders, you will likely go to some of these areas. So it's important that you have a sense of where and who is going to be affected by protozoan pathogens if you are leaving the US to do work elsewhere. All right. With the protozoa, they have two main morphological forms. Okay, so they take two different shapes and they change these shapes depending on what they are doing and where they can be found. So the first is called the trophozoite. Now this is the stage, the part of the life cycle where the protozoan is feeding and reproducing. And this is generally when it lives within the host. So if we're talking about amoebas, this is when it looks like an amoeba, right? You think of an amoeba with its pseudopods coming out. That's the trophozoite form, feeding, reproducing in the body of the host. The second main form is what we call a cyst. This is the infective form. So you ingest the cyst. The cyst is important because it allows for survival of the protozoan in the environment. So in unfriendly habitats, once it's ingested, it undergoes what we call excistation, and it turns back into trophozoites. So all of our protozoans, not all, but most of them tend to have some sort of cycle that involves a cyst in the environment. Once it gets in the host, it turns into a trophozoite. Some of these trophozoites become cysts again that leave the body through whatever method they leave, okay? So cysts undergo excistation and become trophozoites. Trophozoites undergo encystation and leave the host, usually in feces, because a lot of these cause diarrheal diseases. The ones we're going to talk about anyway. Okay, so first up, we have Entamoeba histolytica. This is a main cause of what you have heard of as like traveler's diarrhea, where someone goes to a country with different sanitation and picks up amoebic dysentery. So this is the trophozoite form here on the left. It is motile. Generally with the amoeba, they have pseudopods. This doesn't have a whole lot of pseudopods shown in this particular picture. They have less organelles in their trophozoite stage, but they tend to have a very large food vacuole, right? Like you can see here, these huge food vacuoles, because this is the feeding stage. So they're taking in a lot of nutrients and they're storing them in this food vacuole. This trophozoite then undergoes encystation to become the cyst. These are compact and they're much smaller. So these are on the same magnification. So they're much, much smaller, and they contain multiple nuclei. So you can see all of the different nuclei here, these dark spots. This cyst then, when it undergoes excistation, will allow for the emergence of multiple trophozoites, okay? So our trophozoite, our motile, feeding, active state, or cyst, our inactive, hardy, surviving in the environment state. Okay, so Entamoeba histolytica is ingested when a person drinks contaminated water or eats food that has cysts on it, okay? So you ingest cysts, and that cyst, as it moves through your gastrointestinal tract, gets down here into the small intestine, where excistation occurs. And so this one cyst actually gives us 4 different trophies, or it's very complicated. So 4 nuclei emerge, they immediately divide, and we get 8 trophozoites from each cyst, okay? So these trophozoites now will leave the small intestine and they're going to migrate to the large intestine. That's where they cause disease. Here in the large intestine, they're going to multiply really, really rapidly. And some of these trophozoites are then going to undergo encystation, become these very these structurally different cysts, and then these cysts exit the host in the stool. So this is how the amoeba spreads. So it gets out in the stool, where imagine this happening in an animal in nature, like a rabbit or a wild dog or something. And then these cysts are present in the water supply, on the ground, and are easily picked up by other animals, thereby spreading the amoeba around. Now, also here in the large intestine, some of these trophozoites can actually invade the intestinal mucosa. And just the presence of these amoebas in the colon will result in diarrhea, and we'll talk about how in a minute. But if they invade the intestinal mucosa, they can cause severe issues like dysentery, and they can also, in really rare cases, thankfully, cause an invasive infection. So if they get through that mucosa into the bloodstream, they can move to anywhere that has a lot of blood flow. So the liver, the lungs, even up into the brain, and cause encephalitis, right? So our cyst becomes a trophozoite, which causes the disease. Those trophozoites become more cysts, which then leave the infected host through stool. So Entamoeba histolytica usually causes just a lot of diarrhea. It can cause amoebic dysentery, but we do know quite a bit about how it causes disease. And there are 3 main virulence factors that have been really well characterized. So the first is the galactose-specific lectin. So these lectins are on the outside of the trophozoites, and it allows those trophozoites to attach to the colonic mucosa. So once this attachment happens, it allows for the amoeba to kill the intestinal epithelial cells by production of amoebopore A, the second virulence factor. So amoebopore, like its name suggests, the pore here, it gets deposited on the membrane of host cells, polymerizes, and forms a pore in the cell membrane. And like you guys know, when you form a pore in the cell membrane, whether it's a bacterial cell or a eukaryotic cell, it results in cell death. So we call this contact-dependent cytotoxicity because it requires the attachment of the amoeba to make direct contact in order to kill the cells. And then the third of our virulence factors is actually a group, but we just kind of lump it in as one thing, called the cysteine proteinases. So these are exoenzymes that are secreted into the surrounding environment, and they facilitate the degradation of a number of proteins that you'll see how they can cause a variety of effects. So one of the main things that these cysteine proteinases target are extracellular matrix proteins, so fibronectin, collagen, laminin, so they result in the degradation of the colonic mucosa. They can also cleave proteins of the complement cascade, thereby helping the protozoan escape the immune system. And there's a few specific classes of immunoglobulins that they can degrade as well. So a variety of these enzymes that can have varying effects on the host cell. Okay, so we have attachment to the colonic mucosa, death of those cells, loss of some of our protective epithelial tissues, and degradation of immune response proteins. And the result is a set of really typical symptoms. I'm sorry, really gross picture. The main one would be, in its severe cases, amoebic dysentery. Okay, so again, dysentery is a bloody diarrhea. It's usually very thick with mucus as we are losing that mucosal barrier there in the intestines. And you can see these patches here, such as this, where we have extensive tissue damage. This is a more severe case. So in most cases, tissue damage is minimal, and patients experience milder symptoms. So they might experience abdominal pain, fever, a bit of weight loss, usually intestinal cramping and diarrhea. And this can last for months or years if it's left untreated. In the more severe cases where we do see this tissue damage, again, that's when we get our dysentery. But this is not always present. This is only present in more severe cases. So if it's left untreated, our patient is experiencing dysentery and it's left untreated, they can have these erosive ulcerations, which we see here. They can also wind up with a bowel perforation, or in the event that that does happen, like I said, those trophozoites can then get into the bloodstream and travel to different parts of the body, resulting in amoebic hepatitis, pulmonary amoebiasis, or even amoebas in the brain, causing a whole host of issues, as you can imagine, with an amoeba in the brain. So transmission for this is pretty typically, it's fecal to oral transmission. There can be asymptomatic carriers who are more likely then to spread it to members of their immediate family or people who may live in close contact with them. It's estimated that about 1/10 of the population can be an asymptomatic carrier for Entamoeba histolytica. We mostly see cases of this disease endemic in certain regions of Africa, Asia, and Latin America, or we see it in people who've come back from travel to those countries. One of the reasons that we're still seeing it there is the use of night soil as a fertilizer. That means using human feces to fertilize crops. And if you have a group of people who are positive, who are infected with this, and you're using their feces as night soil, it's going to spread really quickly. And then the other issue, and the bigger issue than night soil, is lack of water treatment in many areas. So if you're getting your water from a stream or a river close by, it's not been treated, it's not been filtered, and you're more likely to pick up something like an amoeba. It can be, Entamoeba histolytica can be diagnosed pretty easily. All you really need to do to diagnose amoebic dysentery is take a stool sample, and you can do a microscopic examination looking for the actual parasites, so looking for the trophozoites and the cysts that were about 4 slides back, okay? So this, you may have heard this term before if you heard of someone taking a stool sample and doing an O and P. So O means ova, in which case you would be looking for eggs from helminths, and P means parasites. So you're looking for things like cysts and trophozoites in the stool sample. And you can see those really easily because they're eukaryotic, they're big. You don't necessarily even need to do any specific stain for those to show up. And they look different enough from other cells that you would find in stool that they're pretty easily diagnostic. You can also take blood and look for the presence of antibodies to the amoeba if necessary, or if you're not seeing anything in an O and P, but you feel pretty confident that that's what your patient is suffering from. The good news is we can treat for amoebic dysentery with Entamoeba histolytica. It can resolve on its own, but who wants to go for weeks or months dealing with watery diarrhea? You can treat it. There's usually a couple of different drugs that are given to treat in 2 areas of the body. So you want to treat anything that's in the stool, and if it has spread to surrounding tissues, if you've had a perforated bowel, if you've had protozoans moving in the blood, you'll want a different drug that'll have better tissue bioavailability. One of the main drugs used to treat this is metronidazole, which is really effective. And of course, if your patient is dealing with severe and chronic diarrhea and thereby dehydration, you'll want to give them fluid replacement, either IV or make sure that they are drinking enough fluids to replace the fluids that they're losing. This is not by any means a fatal disease unless it progresses to a bowel perforation and then a person winds up with secondary bacterial infections. So it can be easily treated and it's not life-threatening. Prevention, these are the sort of preventative tips you have heard before whenever you've traveled to certain areas of the world. So if you're traveling to a region where Entamoeba histolytica is endemic, only drink bottled water or canned soft drinks. You don't want to drink tap water. You don't want to drink water out of a river. Only eat raw fruits and vegetables that you peel yourself, right? So don't eat an apple, eat a banana because you can peel it, throw away the peel, and any cysts would be on the peel. And avoid eating food from street vendors. Right, so those are the big tips for people who are traveling to prevent amoebic dysentery. Okay. So back to our case study where we had our 59-year-old man who developed hallucinations. They thought he had meningitis. So prior to the man's expiration, a spinal tap was performed and the image on the left was obtained. And then to confirm the diagnosis, post-mortem, a brain biopsy was done and the image on the right was obtained. So here on the left, from our CSF, we take some cerebrospinal fluid, spin it down, put it on a slide, and we can see a bunch of immune cells here. And right here in the middle that the arrow is pointed to, we can see the trophozoite form of this pathogen, okay? So it might look familiar based on some slides you saw, or some pictures you saw a few slides ago. And then over here on the right, from the brain biopsy, immunofluorescence was done using antibodies specific to this pathogen. And all of these green dots you see in here are the pathogens. So this whole field would be a tissue section from the brain, and all of these little dots are the pathogens. So that's a lot of pathogen in one little section of the brain. So these aren't images that were with that real case. These were some diagnostic images I pulled from the CDC. If you want to look at whole brain anatomy of what this infection looks like, how it affects the whole brain, there are some pictures there, but I didn't include them because they're kind of gross. So our patient here was not suffering from bacterial meningitis. This thing, this trophozoite, in the middle of the field on the left is definitely not a bacteria. It's as big or bigger than the human eukaryotic cells. What this guy was suffering from was a condition that we call PAM, which I'll explain in the next slide. Okay, our patient here was suffering from a brain infection with the amoeba called Naegleria fowleri. So this particular amoeba, the trophozoites actually enter the nasal passages, and they move from there up to the brain. So usually this happens when a person gets water up their nose, right? Like we've all had that happen when you jumped into a lake or a pool, you get water up your nose and it hurts. And that's how these trophozoites are entered into the nasal passage. We usually see infections such as this happen in warm freshwater lakes. We only see this in freshwater. This amoeba does not live in saltwater. And there have been a number of cases in the last 10 or so years associated with the use of neti pots. So taking water just from your tap and not boiling it and using it in a neti pot. Now this is a really, really rare infection. So from 1962 to 2018, there were only 145 cases. So it doesn't happen very often, but we have actually seen more cases in the last decade than in times before. True story, when I lived in North Carolina, there were 2 cases that occurred in North Carolina during the last 5 years that I lived there. When I lived in Louisiana, there were a couple of cases associated with the use of neti pots, and that's when I stopped using a neti pot because I didn't want a brain-eating amoeba. Okay, once these amoebas get into your brain, they cause a very rapid destruction of brain and spinal tissues, and this is referred to as PAM, or primary amoebic meningoencephalitis. All right. So we don't completely understand how they destroy these brain tissues, but you can see the changes in the image down here. So again, we're looking at tissue section from the brain. These lines are pointing at the amoebas themselves, and they cause sort of kind of like prions do, if you've learned about prions before, these gaps in the brain tissue. So the destruction of the tissue where this should be solid and all connected like we see over here. Now we're seeing the loss of tissue and these big open kind of spongy areas in the brain. As you can imagine, that's not good. That's going to cause a lot of inflammation, and it's going to cause, because most of this is happening in the frontal lobe, our patients start to pretty immediately have some weird behavioral changes or hallucinations associated with the infection. So if you have someone come in, they've been swimming in a warm freshwater lake, they're starting to experience early symptoms of meningitis, you can take cerebrospinal fluid and again look for trophozoites there. However, even with diagnosis, the treatment for this disease is pretty futile. Of the 145 cases, there have been 5 survivors total. The good-ish news is that 4 of those came from 2003 onward. This first one was like in the 1970s, and it seems kind of like a random thing that he actually survived. Of those 4 that have survived in the last 2 decades, 3 of them seem to have recovered normally. 1 of them has some severe mental sequelae after recovering. There's not a real like specific drug to use for this. A lot of the other antiprotozoal drugs don't work well. They don't necessarily make it into the brain. They have low bioavailability in the brain, but there is this one, miltefosine, that shows some promise, especially when it's used in conjunction with some other drugs. So miltefosine is actually an investigational breast cancer drug. It's also used to treat leishmania. So if we can give a person that, some other anti-inflammatory drugs, treat them with hypothermia to bring down swelling in the brain, and that gives a better outcome. But again, it's not 100% protective. So prevention for this guy is key. Make sure public pools are chlorinated, right? You guys can't do anything about that, but don't take your kids to swim in pools that aren't chlorinated. If you're swimming in freshwater lakes, keep water out of the nose and eyes. So look really cool and wear some of those nose clips. Additionally, if it's excessively warm out, if the water's really warm, like in late summer, or if the water levels are low because there hasn't been enough rain recently, don't swim in those lakes. Because one of the issues is there's not a rapid water test available. So we can't just go take some water, test it, and say, oh, this lake has Naegleria in it, don't swim there. We don't necessarily know. So use your better judgment and stay out of lakes that are warm and have low water, all right? Okay, so we're about halfway through today's lecture, and for our question of the day, I have someone here with me who wants to ask you a question. So my son Reese is here. He's 7 years old. What have you been reading, Reese, since school let out?
Harry Potter.
Say it louder so I can hear you.
Harry Potter.
Yeah, you've been reading Harry Potter. You started on book 1. What book are you on now?
Book 5.
Book 5, right. And so you have a question for the students, right? What would you like them to tell you?
What Hogwarts house are you in?
Yeah, what Hogwarts house are you in? He and his sister both want to know. So I will put a survey up on World Class. If you would go over there during your break and click on what house you're in. And if you have no idea what we're talking about, if you never read Harry Potter or saw the movies, Reese, what should they do if they've never read them or seen the movies?
Take the quiz.
Take the quiz. Yeah. Do you remember where the quiz is?
My Wizard something.
I think it's wizardingworld.com.
Well, it's something, my something.
Yeah.
It's my wizard something.
Yeah, I'll put a link there. So if you haven't ever been sorted or if you have no idea what we're talking about, follow the link, answer some questions, figure out what Hogwarts house you're in, and then let us know, okay? Would that be fun, Reese?
Yes.
Yeah, all right. Thank you, Reese, for your question of the day. Why don't you go on out and let me finish recording, okay?
Can I ask Dada?
Yeah, go ask your daddy. Okay. Okay, so we have talked about one amoeba that causes diarrhea. We've talked about one amoeba that causes massive brain destruction. Let's move away from amoebas and talk about a few other protozoan pathogens now. The next one, if you like to hike, if you go backpacking, you've probably heard of this one before, Giardia. Giardia duodenale. It used to be called Giardia lamblia or Giardia giardia. So it's had various different names. Giardia duodenale seems to be the one that people have settled on. You've probably also seen a picture of this. It gets used a lot on the cover of microbiology textbooks because it looks pretty cool. It's sort of this teardrop shaped little protozoan here and has 2 nuclei for some reason that kind of make it look like a face, and these look like eyes, and then it has a variety of flagella all over it that look kind of like a mustache, kind of like hair, and like some weird little legs. So this is a top view if you're looking down on it. If you look at it from the side, it's not flat. It kind of is has this little ventral depression in the middle that kind of looks like a sucker, and it's thought that that might be how it helps to attach to cells in some ways. So this is the trophozoite form. It's got its flagella, it's got some cilia, it's motile, it's swimming around, it's feeding. It too has a cyst with multiple nuclei in it, like the amoebas do. So you can see in the image down at the bottom, this would be a stool sample. Here on the left is the trophozoite. Kind of looks a little like a horseshoe crab to me. And then over here on the right is a cyst. So we can see them both in the stool. Okay, so like with Entamoeba histolytica and most other pathogens that cause gastroenteritis of some sort, it is fecal to oral. Those of you who camp, who hike, you know that this comes from contaminated water. So that beautiful mountain stream that looks so clear and clean and you want to take a drink from it because it's hot and you're thirsty, don't do it. That's where people tend to pick these up, is when they're out hiking. Because Giardia can live in the intestines of a variety of animals. And as those animals defecate and snow melt runs off into the streams, these protozoans get into stream water. We can also pick it up in public swimming pools because these cysts can persist in lower levels of chlorine. So in our little diagram here, we've got someone ingesting cysts. So those are the part that you're going to ingest. The trophozoites don't survive outside of the host. Once they enter the body, they undergo excistation into that motile trophozoite. Those trophozoites then divide and can start to cause disease. Now, not everybody is going to experience symptoms. Some people will just have an asymptomatic infection and they'll clear all the trophozoites from their body relatively quickly. But like with our amoebas, some of these trophozoites then undergo encystation as they move toward the colon. And then we get cysts and trophozoites that are expelled in feces. Outside of the body, I should say, only the cysts survive. The trophozoites all die. So these cysts can live for a long time in cold water. So then you drink from your river stream or you use it to clean your produce while you're on your hike. And then you ingest those cysts and you can wind up with giardiasis, which is what we call the disease. This is a very long-lasting diarrhea. It's one of those diseases that it's easy to kind of forget what you may have done previously because it can have a 1 to 3 week incubation period. So if you went hiking 3 weeks ago and you don't experience symptoms till now, you might not necessarily connect that, oh yeah, I went hiking and I took a sip of water from this stream, or I washed my apple off in this stream. But you'll know that you have Giardia and not something like mild food poisoning because the stool, the diarrhea caused by Giardia, is described as greasy and very odorous. So it's terribly stinky. It's like oily, greasy looking, and it tends to float. And this is in part caused by a shortening of the microvilli. We'll talk about that on this next slide. So we know that Giardia causes disease. Here's our little Giardia right here. This sort of depression that you can see here is the ventral depression with its flagella coming off of it. We do know that Giardia infection results primarily in a malabsorption of nutrients. So particularly your body is not absorbing fat very well from your diet, as well as carbohydrates. So because there's still a high fat content remaining in the colon, it results in these floating and greasy stools that smell very, very badly. And biopsies of people who are infected with Giardia shows that the microvilli tend to be shortened or flattened, which is thought to be the reason why nutrients are not being well absorbed across the intestine. But we don't know any particular virulence factors that are responsible for this. It's just something we've noticed that happens that we think causes the disease. So again, diagnosis of Giardia, like with Entamoeba histolytica, we can take a stool sample. It can be somewhat challenging because the trophozoites and cysts aren't always found. So they may only be found intermittently if a person has a chronic case where they're experiencing diarrhea for months, or if it's a subacute case where a person may only experience diarrhea like once a week and it doesn't seem too bad. So we won't always find these there. You can do like an ELISA to directly detect Giardia in stools, but usually in a really acute case, you can find trophozoites or cysts in the stool. Additionally, diagnosis can usually just be done clinically based off a description of or a stool sample that you've been given because of the smell, because of the floaty, greasy nature of the stool. Again, people can be treated for Giardia. It clears it up pretty quickly. There's a couple of anti-protozoan drugs that work really well, metronidazole and quinacrine. The only issue here is that these are contraindicated in pregnant women because they can be teratogenic. So during pregnancy, you may need to find a different way for treatment. And prevention, as always, is key. This disease can spread really quickly from person to person because of the chronic and voluminous amounts of diarrhea. So if you are, living in a family home, family members, playmates of young children who have giardiasis can be treated prophylactically. Again, this could be important because of that 1 to 3 week incubation period. So in that 3-week incubation period, you can treat someone so that they never experience symptoms. Again, easily spread person to person. And if you are out hiking, backpacking, camping for long periods of time, and you take water from the stream, remember you need to treat it with something like iodine, with some of those, I'm not sure how well those like UV light things that you can put in your water, I'm not sure how well those work against Giardia. Or filter your water. Use a specific water filter to make your water safe to drink so that you don't pick up Giardia and come back from your wonderful trip and feel terrible for a few weeks before you go to the doctor. Okay, so that's the last of our diarrheal diseases. So let's talk about one that you've probably also heard of called Toxoplasma gondii. And this was the quote from Ed Yong on the first slide. So toxoplasma causes the disease that we refer to as toxoplasmosis. And it's estimated that about 25% of the world's population is infected with toxoplasma. And that by age 6, somewhere around 11% of Americans have been infected. So this is a zoonotic disease, one that we get from animals. Mammals and birds are the major reservoir for toxoplasma, but cats are what we call the definitive host. That means in order for the parasite to fully mature, to go through sexual reproduction, it has to get into a cat. Otherwise, it's in what we call a dead-end host. It cannot complete its life cycle. People get infected with toxoplasma through a few different ways. One is the consumption of undercooked meat. So that could be pork, lamb, venison, and shellfish. Through ingestion or inhalation of contaminated material. So this is when you hear about cat litter. Because cats are the definitive host, they can shed the toxoplasma in their feces. So by cleaning cat litter, you can be exposed by inhalation to toxoplasma. And then congenital infection, so transfer from the mother to the fetus. So this is why you've heard that pregnant women should not sift cat litter, which may not be true, because if you grew up with cats, you've already been infected with toxoplasma. So you're not going to get reinfected if you're pregnant and sifting cat litter. But ladies, don't tell your husbands that. Make them sift the cat litter anyway, or your non-pregnant partner. Make them do it if you're pregnant, okay? That's what I did. Take my advice. All right. So toxoplasma, excuse me, toxoplasma has this kind of normal cycle where small mammals like rats or birds pick up the cyst form, which is called an oocyst in that case, but you don't need to know that. They pick up the cyst form in nature from, water, from the ground. They ingest it, and it moves as it replicates in the little mouse or bird body. It moves into their brain. And this is where Ed Yong calls it a puppet master, because here in these birds and small mammals, it makes them not afraid of cats. So the normal response of these guys is to run away. But now, toxoplasma in their brain is making them not afraid. And in fact, it's kind of making them like interested in or attracted to this cat over here. It's also at the same time making their motor performance poorer, so they have less reaction time to run away if the cat pounces. So these little infected animals will essentially walk right up to the cat, and then the cat eats them. So then when the cat eats them, it's ingesting cysts that were in the tissues of these animals. It gets into the cat where it can undergo its full replicative cycle, including sexual reproduction. And then those cysts are excreted in the feces of the cat. So from here, it can go on to, it can be picked up by other animals who are grazing off of feed. It can get into their tissues. And if we eat those undercooked, we can become infected. These cysts can then become trophozoites, undergo excistation, and we can get infected. We used to be able to get it from blood transfers. That doesn't really happen anymore, right? We don't get a lot of bloodborne pathogens in transfusions anymore. Or humans can obtain it, again, through sifting kitty litter, from eating unwashed fruits and vegetables, or handling these after sifting the kitty litter without washing your hands. I don't know anyone do that, and can infect our human and can cross the placenta. So it's a really strange replicative cycle for these protozoans, which I think is part of what makes them so fascinating. Okay, so what kind of disease does toxoplasma cause? You've probably heard of it, and you've probably only heard of it in the context of pregnant women not wanting to get it. For most people, it causes a really asymptomatic infection. A healthy immune system can control toxoplasma, can get rid of it without really any sort of symptomology. It does cause an actual disease or a true disease in a really small percent of people who are infected. And this is not really anything specific. So a little bit of fever, sore throat, some lymph node enlargement. But it's usually self-limiting, and it goes away on its own in a week to a couple of weeks. But the parasite can remain inactive in the body, and it can become reactivated if our person becomes immunocompromised. So toxoplasma is really problematic for immunodeficient individuals, and sometimes we see severe toxoplasma and brain involvement with toxoplasma in late stage AIDS patients. And this will appear as things like encephalitis, myocarditis, pneumonitis, and behavioral changes. If an immunocompromised patient gets to these points, it's a really, really grim outlook. They can develop a chronic or a subacute form of encephalitis that's hard to control or hard to diagnose. That can then turn into excessive brain lesions and fatal disruption of the heart and the lungs over time. Again, it's also very problematic for a fetus. So it's transmitted mother to fetus and this can happen when it's worst to happen is during the first or second trimester. So if we have a mother who's never been infected before and she gets the primary toxoplasmosis infection during the first or second trimester, then she can pass it on to the fetus. If the mother was infected before she ever became pregnant, chances are the immune system is going to take care of any infection, and there won't be an issue of it being passed on. If the fetus is infected, the usual occurrence is a spontaneous abortion or stillbirth of the fetus. Should the fetus survive, they can develop a CNS infection, and and be born with severe issues such as intracranial calcification, hydrocephalus, a number of other things like microcephaly, and convulsions immediately after birth. For some children, even symptoms are not apparent at birth, so they seem completely normal with no issues at birth, but they can appear later in life, so a few months or even to a few years after birth. Now, while most normal healthy people are asymptomatic or have just like really mild kind of symptoms, some people who have chronic toxoplasma have reported some severe behavioral changes and thought changes. Um, and one of the really interesting things that's happened um, is there was a study that showed that people who are infected with toxoplasma are 2.5 times more likely to get in car crashes. And it seems in part due to decreased reaction times because of infection in the brain. And there's also a link, I couldn't find any actual data on it, but there's this suspected link between people who participate in extreme sports like base jumping and toxoplasma infection, because it does decrease the fear centers of the brain. So I don't know if that one's true or not, but here's a link to an interesting article about toxoplasma infection and how it changes people's behaviors, in case you're interested. So it can be diagnosed generally looking for antibodies, IgM, or culturing it and looking for cysts or the trophozoite form. And there is treatment for it. The treatment is most effective in healthy people who have true disease. It has to be given for a really long time to kill off all of the trophozoites, and it doesn't kill off the cyst stages. All right. So we have, I believe, one final pathogen to talk about. This is another one you've probably heard of. It tends to just get called trick, but it's Trichomonas vaginalis, another STI. So this is, in industrialized nations, the most common protozoan disease. As you probably know, excuse me, let me get a drink of water. Being an STI, it is transmitted sexually. Usually, when we see trick, usually there's a co-infection with some other STI like gonorrhea or chlamydia. And often we see that a person with one STI can have more than one at a time. This particular one is more common in people who have multiple sexual partners than in someone who has just one or two sexual partners. So unlike chlamydia and gonorrhea, infection in women in this case does result in very severe symptomatic infection. So it results in what we call vaginitis. This is characterized by itching, irritation, and a greenish discharge. So definitely something that you're going to notice, unlike gonorrhea and chlamydia, which are often asymptomatic until it's gotten much worse. So here women do have a symptomatic infection. Men usually are symptomatic too, although for men it appears more as urethritis or painful urination. So in both cases, different than the other STIs that we've talked about so far. Trick is pretty easily diagnosed. The classic way to diagnose it is to take some of the vaginal fluid or a cervical smear and do microscopy looking for the presence of the protozoans. So you can see them. I have the arrow pointing at some here. Here's our little kind of teardrop shaped protozoans, and you can see the flagella on the ends of these. So there's some up here where you can see the flagella as well. And then these larger flat things you can see over here would be normal human cells. This is not, I mean, this was classically the way that it was done because it was easy and available, but it actually has really low sensitivity. And if you don't know what you're looking for, it can be easy to miss like these little flagella and get what you're looking at. So the better way now is to use a rapid antigen test of some sort or a PCR-based test if necessary. And of course, like with all the other STIs we've talked about, prevention, the best prevention is safe sex, right? We can teach abstinence all we want, but the best prevention is to teach safe sex. I included this picture of these guys up here because they're really cool looking. You see they have this undulating membrane at the top, which is actually an extension of the flagella that comes out here on the back. And they have these weird little flagella at the front that kind of look like a strange mouthpiece or something. So they're pretty cool looking little protozoan. Okay. All right, guys, that's the end for today. That's all that we're going to cover for our protozoan parasites. Next up, next week, we will talk about mycoses or fungal infections. And that, you guys, will be the last lecture of the semester. So have a good rest of your week. Prepare for TBL. If you're listening to this before TBL, go take the little survey I put on there and answer my son's question. My daughter is also dying to know what Hogwarts house you're in. And I hope you all are enjoying your last couple of weeks and are ready to gear up and turn it over for finals. Bye.